Canolfan Gwasanaethau. Good afternoon, everybody. While we wait for others to join us, please, do introduce yourself in the chat. So give us your name, job title, organisation, and maybe tell us what you're having for lunch today. And we'll get started shortly.
The part G for your building regs.
Brilliant. For those that are just joining us, please just introduce yourself in the chat, and we'll be starting in the next couple of minutes. Yes, Tricia, we will be, just to let people know that we are recording today's session. So if you don't want to be seen on camera, then please switch your cameras off and your microphones on mute. But yeah, we will be recording the session. They'll be made available for you to view afterwards on our YouTube channel. Good to see you, Pauline. Healthy lunch of chocolate biscuits so far. There we go, brilliant. Great, just got a few more coming in the room. If people can keep their microphones on mute, that would be great. Right, looks like we've got a good number in the room, so I will start things off. Okay. Canolfan Gwasanaethau Cyhoeddus. Good afternoon and welcome to our brand new Lunch and Learn series, What Does Good Look Like? Brought to you by the Centre for Digital Public Services. I'm Mike Erskine, Communications Manager at the CDPS and Chair for this 5-part series. Today, we embark on a journey of digital transformation success stories from across the public sector in Wales, featuring best practice case studies from health boards to local government and arm's length bodies. So whether you're a seasoned digital professional or new to the digital transformation journey, this series promises to equip you with the knowledge and inspiration needed to drive meaningful change in your organisation. Before we kick off the session, it's important to note that today marks the start of Mental Health Awareness Week. And at the CDPS, we always talk about the importance of looking after our mental health and well-being, especially in the fast-paced digital age we now live in. Throughout this series, we aim to highlight the importance of prioritising the person in all endeavours, ensuring that the needs of both our staff and the people who use our services are at the forefront of our efforts. In today's session, we are delighted to have Tracy Bell, the Head of Digital Planning, Plan Care and Community at Swansea Bay University Health Board, and Nerys James, Digital Programme Manager. And they will be sharing their insights from their fascinating journey with the Hospital Electronic Prescribing and Medicines Administration System, known to many health circles as HEPMA. The HEPMA system has effectively replaced paper medication charts across secondary settings in Swansea Bay, marking a significant milestone in the digitalisation of healthcare services. Today's session will provide a reflection on the implementation approach of HEPMA, covering successes, challenges, benefits realised to date, and insights into lessons learned. Tracy and Nerys will delve into how the implementation engaged with people, processes, and technology, offering invaluable insights for public service professionals navigating similar transformations. Just to say, we encourage active participation from all of you, so please do feel free to share your questions for Nerys and Tracy and your own insights and experiences in the chat throughout the session, and we will make sure there is time at the end to cover what is said. So without further ado, I will pass you on to Tracy and Nerys. Croeso pawb.
Thank you very much, Mike. I'm just going to take control. Okay, can everyone see me moving the slides? Okay, so just to give you a bit of background, Swansea Bay University Health Board are the pathfinder for Wales in terms of the e-prescribing programme. So there is a national programme at the moment ongoing in terms of an implementation of HEPMA across Wales. But Swansea Bay started the journey in 2020, prior to, and obviously that was right in the middle of COVID, and implemented in Neath and Singleton. And we have just in the last month completed the rollout across all medical and surgical wards in Morriston, Neath, Singleton, as well as mental health sites. We do have learning disabilities left to implement. So it has taken us a while. So we do have a lot of lessons to be learnt. And it's been challenging, and hopefully you'll appreciate some of that as we go through the slides. So what were we trying to achieve? As you're all aware, paper medication charts were at the end of a patient's bed, stored with paper nursing documentation at the bedside or near to the patient. They're often unavailable when required. They're with the doctor. They might be in treatment rooms, in the pharmacy department. So when somebody wants to look at the paper chart, they often have to go around the wards trying to find that piece of paper, which was obviously time consuming. They're also susceptible to damage, so there could be fluids dropped onto the paper, and they're obviously very difficult to interpret administrations and emitted doses. So these are just some examples. You can see the quality of some of the paper charts. So I think you can all appreciate they're quite hard to read. So you can't tell, so the bottom left, you can't tell if that's 1.25 micrograms or milligrams. I know I would really struggle to understand any of the content that's on those paper charts. So some of them are completely illegible. So as you can see, implementing an electronic record was paramount for patient safety. So this is an example of the electronic drug chart. We're live with a system that is currently supplied by System C, but it has been lots of things over the years. So when we were using it, was JAC was the software provider, and it was called WellSky. They do provide the National Pharmacy Stock Control System as well. So we're live with System C. There are a number of other providers out there. So that shows the electronic drug chart, which is a good representation of how it used to look on paper. So it was very familiar to users, and you can see from that that vertical line is what administrations do at that time. Some of the features are there's mandatory safety features. So it's mandatory that you record allergy and the initial VT risk assessment when the patient's admitted. They are mandatory, so you can't carry on in the system until you've completed those things. There's also clinical decision support, so it'll alert the user if there's any allergy conflicts. It checks for interactions across drug sets and looks for duplication, and there's also formulary support. Is that slide clear to you? It doesn't look very clear to me. Is it clear for you?
Hear you, Tracy.
Oh, good. Okay. I can see it properly now. I can't see it very clearly, but let me just see if I can.
We can just see the top half of it, I think.
Yeah,
Tracy.
I know, yeah. It's not coming through very well, is it? Okay, hold on. Okay, so the implementations, there's two different approaches to an implementation. So there's a big bang approach and an incremental rollout. So a big bang approach is obviously where you would pick a couple of sites and you would choose to go live. So you may choose to go live on all of Morriston, for example, on all medical wards at one time, or all medical and surgical wards. The advantages to that approach are obviously it removes dual processes. So at the moment, if you were live on Ward A, for example, and then that patient and that ward was HEPMA enabled, and then they move from Ward A to Ward B is not HEPMA enabled. They're going from electronic to paper. So one of the advantages of going big bang is all wards would be live in one implementation, which obviously reduces risk because you don't have dual processes running, so you are purely electronic and not a mix of paper and electronic. There's a shorter implementation period, obviously, and the hospital can experience the full benefits immediately after implementation. However, there are disadvantages with that. So obviously, it's resource intensive to undertake the transcriptions, because when you move from paper to electronic, they all have to be clinically verified again when you're moving from that paper chart to the electronic chart. There is short supply of pharmacy staff across Wales at the moment, so it does require a pharmacist to do that clinical check, and you would need an army of staff to be able to do that safely. There would be an upfront training requirement as well, rather than an incremental approach. One-to-one training wouldn't be possible, so you'd have to employ large volumes of trainers to get through that training. And it's the availability of staff as well to dedicate that time to the training, because clinical staff have to do that on the job. Business process mapping, scoping and configuration would be extensive. To do it in a big bang approach, you'd have to do all of that up front. And what we found is doing it in an incremental way, you go live, you learn from that, and you adjust your configuration. If any issues arise during implementation, they could impact the entire hospital at the same time, which causes significant disruptions. So the other implementation approach is the incremental rollout, which is what we've used in Swansea Bay. So as I said, we started this implementation in 2020. It's just taken us a good while to do that. And whilst it's been challenging, we have learned a lot from that experience. So the resource required to undertake the transcribing and clinical checks is more manageable. So what we did it on a ward by ward basis. So we'd transcribe all of the paper charts onto the electronic chart, and then the clinical check is done. But again, the disadvantage is that we did have dual processes in place where patients are moving from a non-HEPMA ward to a HEPMA ward and vice versa. So there were paper charts and electronic charts in the mix. The training is more focused, so we were able to do that on a one-to-one approach. We did digital champions were identified to support each clinical area. However, there is a longer implementation period. Again, as I've already touched on, you could go live in one area and then learn from that in order and move on through that incremental approach, learning throughout the implementation. Implementation fatigue, it has been really hard on our HEPMA team, because they have been implementing. Yes, we've had pauses due to resourcing issues, but they have been implementing for a long period of time. So it is difficult for the digital staff as well as the health professionals on the ground. And it has allowed for other implementations of other digital solutions in parallel, such as WNCR and Signal. Again, the potential digital disruption due to continued implementations with the incremental approach. So agreeing the implementation order, we really had to think about patient flow in this one. So when we started, we piloted on a ward where there was the average length of stay was longer, but we soon found that the flow, so consideration of the front door, so people were coming into the assessment unit with a paper chart and then moving on into a ward that was HEPMA enabled. So we were going paper to electronic. The volume, we couldn't cope with the volume, so we had to readjust the implementation order and go and do the assessment unit up front, so that then they started on a paper chart and then they flowed through onto each ward. So that's really just telling you that we took an iterative approach in terms of the implementation as well, in considering patient flow, and adjusted it as we went along through the implementation. And I'm going to pass on to Neris now.
Okay, good afternoon, everybody. So I'm going to start with describing. I think it's really important to acknowledge the amount of planning that needs to go into an implementation before we even think about reaping the benefits of EPMA and solutions that are available to us. Transcription for go live on this slide, for example, There's a huge amount of work that goes into preparing a ward before they are ready to go live. If you can imagine, you've got your paper charts that need to be actively used by the patients, but also need to be transcribed digitally to enable you to go live and take those patients on that digital journey. So there was a lot of work in ensuring that we have the Teams has gone on hold from our screen, so I'm not actually, I think we're back. So for our teams, what that meant was actually transcribing onto the digital EPMA solution and then suspending those medications, clinically checking them by a pharmacist, and then restarting them only when that patient was ready to become a live HEPMA patient. And obviously then there are all those safety elements around ensuring that there aren't those dual paper processes and electronic processes. So lots of clinical safety considerations there. And also about pre-configuration. You're never going to have a system that is pre-configured with everything that needs to work in the ways that you need to work, and you have different areas across your sites that will work slightly differently. So there needs to be a bespoke element of configuration. So this slide just gives you an idea of the sort of work that went into that configuration initially for our pilot site in Neath Talbot, which was one of our smaller sites, but with some complex medical patients. A lot of workarounds we had to come up with, because as I said, no system will always work exactly as you need it. There will be tweaks. So we needed to set up governance groups and working groups and agree those clinical configurations and how they would work safely. They were then supported by SOPs. SOPs need to be available 24/7 because of the way hospitals work and things. So everybody needs to be fully cited on exactly how they should be working safely at all times, regardless of whether the support staff are present or not. Testing, often with any digital solution, we have upgrades and these need to be thoroughly tested. We write test scripts. There's a huge amount of effort that goes in to those testings, and obviously we've implemented over a 4-year period, so we've had a number of upgrades, and it's been about managing the team and ensuring that we have enough resource to both implement, support users that are already on HEPMA and look at that testing element as well at the same time. Drug file configuration, the system we use currently is not DMD compliant. That will be coming a later version of our software. So that meant an initial build of approximately 4,000 drug files, which is a lot of work, a lot of checking, particularly from a clinical pharmacist perspective. And then user accounts. It wasn't as I said, configuration needs to be bespoke. Users need different levels. Student nurses need different permissions to registered nurses, for example, consultants to junior doctors, and allied healthcare professionals and so on. So there needs to be a lot of input and thought and planning into the configuration prior to the implementation phase. As lovely as it is to have the EPMA, we're very lucky to be the pathfinder in Swansea Bay and reap a lot of benefits, particularly those around the time-saving elements. But I think it's really important that we acknowledge some of the challenges, because with any implementation, there are challenges. We've already touched slightly on resources. Now, for us in Swansea Bay, it was particularly difficult to find the clinical pharmacy resource. Our approach was to have a team independent of our pharmacy team. So our pharmacy team sits in our digital team, but we did come up against some challenges because there are only so many pharmacists and pharmacy technicians available out there. There was also the thing of fixed term contracts. Sometimes, depending on the type of funding that's supporting your implementation, you're not always in a position to offer permanent contracts initially. So that was a challenge in the recruitment process for us. Go live support, I've already touched on, the amount of effort that goes into the transcription of the charts, the clinical check and the resuming of charts. Implementation pauses. So, as you've heard, we started this implementation in 2020. Within the first month, we were hit with COVID, unfortunately, and that presented pauses. We have other things like junior induction intakes, staffing issues, building work. We came across some building work on our second site, and reconfiguration of wards, different strategic projects across the health board that would impact the implementation. So there needs to be a lot of refinement, and as Tracy said, a lot of review, and implementation orders will change because of all these sorts of challenges. Patient flow, again, you really need to acknowledge the type of cover that ward have got. Are you going to bring an EPMA implementation to a ward with most people on leave that week or running on perhaps locum cover? So lots of considerations, and particularly around that COVID time where there was a lot of remote working, infection control requirements, and more challenges than you would normally expect them. In terms of usage then, just to give you an idea, first of all, these charts are for illustrative purposes only, but to date, we are now live in 75 wards or clinical areas. We have admitted over 32,000 HEPMA patients, charted over 11 million doses, that obviously increases daily, and over 1 million medications prescribed digitally. And just to touch on the benefits then, some of the key benefits that have come out are around clinical safety, as Tracy mentioned, the clinical decision support, having that, we can see that the prescription just from the initial evaluation, how many interventions we had that around the allergy conflict for penicillin, for example, blank boxes for nursing, you automatically have this 100% compliance with EPMA. If your configuration is to prevent people being able to move on from an administration without accounting for that dose. And we also found that it released time to care. And I think it's important to note that that's not a benefit that's realised very early on. It's something that needs to embed, and it takes time for your staff to get used to the system. People will have different rates and levels of adoption and things. And the main things then to come out of staff experience are around safer practice, increased legibility, remote access. Think about your geographical spread of sites, there are a lot of benefits. I think our prescribers particularly favour the no more chart rewrites. That is definitely a key benefit from a user's perspective. And in terms of where we are now, I won't go into too much detail just in the interest of time for questions. But we started in 2019 with the configuration. We went live in 2020, and we are now live across all sites and our community hospitals, apart from our learning disabilities implementation, which is scheduled for this summer and will be hopefully completed as soon as we've upgraded to the latest version of the software. Thank you. Lessons learned, there's a few just on the screen for you. I won't go into these in too much detail. I think I'll just pick up out the just a few dashboards. Use dashboards for reporting, prioritise your wards, choose which patients need to be seen most urgently, use HEPMA, use the information that you've got, pause your implementations, don't put too much effort into the order of planning up front because that needs to change. Devices, think about what devices do users need? How big do those screens need to be for them to clearly see that drug chart? Where can you store these devices? Are they going to break? Do you have the room for them? There's a lot of things around devices to think about. We do have an evaluation that can be shared, and a lot of this is about cultural behavioural change. It's not easy getting somebody who's worked on a paper drug chart for 30 years and doesn't want to change. So, it's about being patient and working and engaging with those stakeholders and providing that continuous support to help them on that digital journey. Thank you. Any questions?
Thank you, Neris. Thank you, Tracy. As a whistle stop, but really, really good summary of the journey that you've been on and challenges. And look at, you can just see, as Simon Jones put in the chat here, just the excellent project and the results that you've had already. I think with my comms hat on, I'll quickly ask one before we go to the floor. Is how did you ensure that effective communication and collaboration between different departments and stakeholders involved in the implementation? What was the kind of comms effort, I guess, around it?
Yeah, so I think one thing that was really important for us in Swansea Bay was that this was very clinically led. Clinical digital champions in each area were identified, and much of the success is due to working with our clinical leadership and our support that we've had from the people on the ground, really, the frontline staff. We've worked really closely with our stakeholders and ensure that their needs are met in the configuration process. We have working groups, clinical reference groups, and I think without the support we've had from them, we wouldn't be where we are today with the success of the implementation. So definitely involve as many stakeholders as you can, and involve them in those decisions around the configuration particularly.
Yeah, excellent. Simon does ask, any direct patient benefits that you've seen or come out of your feedback?
I think, from my experience, I think it's got to be the allergies, isn't it? It's got to be so much safer, and particularly with certain cohorts of patients and things, having that legible information, and that can be shared as well. So, the remote access, the faster prescribing, there's no more waiting for a doctor to travel to a ward, especially, for example, in mental health, there's no more traveling between sites when perhaps you've got the one consultant covered 2 or more sites. Things are happening more quickly. Medications can be reviewed more safely and more timely. So in terms of direct patient benefits, I think it's very much around the safety aspect that EPMA presents.
Yeah, just to add to that, Mary's touched on it, the mental health sites. So our mental health sites are geographically spread from Powys, Cardiff, to Swansea, and the pharmacy staff support all of those different sites. So the remote working capabilities that this has introduced is, we haven't done the evaluation for mental health yet. It's a shame, otherwise we could have, because it was a great success in mental health, and we are in the middle of evaluating that. But one of the things that you do find with HEPMA is it can be more timely for pharmacy. It can take more time for pharmacy staff during discharge, but the pharmacy staff within the mental health service have been brilliant, because it has saved time for them because of the remote working capabilities, because they would have to support all of the different sites. So that's been a huge benefit within that service.
Yeah, and Simon says here, because he was thinking about the waiting for take-home meds. I think that waiting time. Yeah. Okay. Brilliant. Is there any more? I've got one more. We got a question from Rebecca, who is Rebecca Godfrey from the Welsh Revenue Authority, who's actually going to be one of our speakers for a future Lunch and Learn session. So good to see you, Rebecca. Rebecca said, you mentioned resourcing challenges, and I think we can all sympathise with that. How did you overcome those resource challenges?
We actually didn't know how we were going to complete the last implementation in surgery in Morriston Hospital. We have a digital e-prescribing pharmacist who was on maternity leave. We'd gone out to recruitment multiple times, couldn't appoint into that post. We did go out and ask companies like Frontline Support, I think they're called, whether they could give us staff, but there is a pharmacy shortage across Wales, so I think everyone was feeling the same thing. The only way they could provide us with pharmacy resources were existing pharmacy staff who work in different hospitals, doing it on the weekend, but we couldn't do it that way. So we did look at, could we do the last implementation, Big Bang? We looked at whether junior doctors, for example, could support with the clinical checks. We looked at lots of different things, but in the end, we actually managed to get an agency resource in to help with those clinical checks. And we did finally manage to recruit into that e-prescribing post while our clinical lead was on maternity leave. So we did manage to recruit in the end. And the other thing, the pharmacy staff within Morriston Hospital weren't able to support with the clinical checks because of the resourcing issues there as well. Again, in mental health, they were completely on board with the whole implementation, and they did get involved with the clinical checks. So the pharmacy staff in mental health almost took that pressure away from the HEPMA team as well, because they were able to support with that. So we did manage it in the end, but it was very challenging. But it was literally agencies, continually trying to recruit.
Brilliant. Is there any more questions from the floor? I mean, one question just to finish things off. I mean, in hindsight, is there anything that you would have done differently during this journey that you've been on? Looking back, is there anything that you would have done differently, or?
I think maybe you know, it's easy to say you've got your lessons, isn't it? I think maybe I would have taken a more big bang approach in certain areas, perhaps.
Big bang, yeah.
Yeah, I think perhaps less pauses. I think a lot of the time the pauses were dictated by the service for various reasons. But I'm not, you know, I'm not sure that pausing was that helpful in that, you know, it did
delay the inevitable, really, didn't it?
Yeah.
You know, we had to do it in the end anyway. And one thing, I guess, is I think we were always worrying about doing surgery in Marston Hospital, but because we had implemented so far, a lot of people have been trained up to that point. So it did make that last implementation a bit smoother because so many people had been trained by the time it got to that.
Yeah.
If you had all the army and all the resources in the world, a big bang approach would be better.
One thing,
but it's just those resourcing challenges.
We did on the final implementation mandate e-learning.
Yes.
Because we built an e-learning package, we mandated that training. That definitely helped.
Yeah, which was supported by all of the clinical leads. So we had medical directors, you know, making sure staff within their sections had done the e-learning. So I think all of that as well, which we didn't take that much of an approach earlier on in implementation.
Fantastic. Okay, thank you so much both. I mean, yeah, I just want to extend our thank you to you. Thanks to all the questions that have come in. If you obviously have got any more questions or would like to get in touch direct with Tracy and Neris, I'm sure they'll be happy to maybe share their direct contact details for you to reach out, and we can help make that happen. I just wanted to flag to you a new the rest of the series and what it looks like. So we've got another session next week, part 2 of this What Does Good Look Like series with Vale of Glamorgan. So we've got Nikki Johns, head of digital at the Vale of Glamorgan. Nikki was recruited into the head of digital role just last year and has already made a massive impact in a short period of time. So Nikki will be talking about building a DDAT team at the Vale and the bumps and the success she's had along the road. We'll have a break then for bank holiday, and then we're back on the 10th of June with the Chief Operating Officer of Welsh Revenue Authority, Rebecca Godfrey, to talk about building an agile working culture by meeting user needs and user-centered design are integral to how they build any new service. And on the 10th of June, we are joined by Lincumry Housing Association service design team to chat about a nursing home modernisation project to bring 3 paper-based nursing homes online. And finally, to wrap up our series, we've got Newport Talbot Council to talk about the cost savings and efficiency savings using robotic process automation. So a real varied bunch. So if you have a project that you would like to showcase for a future Lunch and Learn series, it doesn't matter how small a win it is, please drop us an email and we will pick this up. And finally, if you do have time, we would really value your feedback on today's session. We've just got a few questions here. We'll pop this in a follow-up email as well, but just wanted to get your sense of, if this Lunch and Learn made sense to you, if you learned something new today, any sort of learnings that you want to take into your own organisation, and what is your main takeaway from today? So no pun intended with the lunchtime learning, but please give us your feedback. And please join us for the next sessions. So just want to wrap things up. Thank you again to Neris and to Tracy for fascinating insight into your project. Good luck with the next steps in your continued journey on this. And have a good week. Have a good rest of the week, everybody, and we'll see you next Monday. Neris and Tracy, I don't know if you can hold on for a second. That would be great.